Here's a detailed summary of the article Efficacy and Safety of Alfaxalone, compared to propofol in canine refractory status epilepticus, a pilot study. Introduction. Status epilepticus, SE, is defined as prolonged seizure activity lasting more than 5 minutes, or multiple seizures without a return to consciousness between episodes. It is a life-threatening neurological emergency, and its management becomes particularly challenging when it becomes refractory status epilepticus, RSE, which is resistant to first and second-line anti-seizure medications ASMs. The mortality rate in SE is reported between 25.3% to 38.5%, making early and effective intervention crucial. The standard first-line treatment for SE is benzodiazepines, BZDs, which work by enhancing Greek letter gamma-aminobutyric acid, GABA-ergic transmission. However, in cases where BZDs fail to stop seizure activity, other treatments such as phenobarbital PB levetiracetam-lev and general anesthetics like propofol, PPF, or ketamine are commonly used. Propofol, a GABA-A agonist and N-methyl D-aspartate NMDA receptor antagonist, is one of the most commonly used drugs in treating canine RSE. It is often administered through a constant rate infusion, CRI, due to its short half-life and fast clearance. However, propofol has several known side effects, including respiratory depression, cardiovascular suppression, and, in rare cases, propofol infusion syndrome. This has led to the exploration of alternative treatments such as alfaxalone alpha-neurosteroid anesthetic with anticonvulsant properties, acting on GABA-A receptor subunits. Alfaxalone can be administered intravenously or intramuscularly, offering an advantage in cases where intravenous IV access is difficult due to severe seizure activity. The study compares the efficacy and safety of alfaxalone administered intramuscularly IM followed by a CRI to propofol CRI in dogs with RSE. This pilot study aims to determine if alfaxalone could be a viable alternative to propofol in the treatment of canine RSE. Materials and methods. This pilot study was conducted as a multicentric, randomized clinical trial across multiple veterinary centers. 20 dogs diagnosed with SE and refractory to first and second line ASMs were enrolled in the study. The dogs were divided into 2 treatment groups. 10 received propofol, PPF, and the other 10 received alfaxalone alf. Both groups were treated with continuous infusions of their respective drugs for 6 hours. Study participants, the dogs included in the study were client-owned pets with generalized or focal SE. SE was defined as seizures lasting 5 minutes or longer, or 2 or more seizures without full recovery of consciousness, inclusion criteria required dogs to experience RSE for at least 30 minutes following administration of first and second-line medications, midazolam, diazepam, phenobarbital, or levetiracetam, exclusion criteria included suspected reactive seizures, e.g., metabolic causes, and lack of owner consent. Treatment protocols, propofol group, PPF. Dogs were given an initial IV bolus of 1/4 mg/kg propofol followed by a CRI of 0.1 to 0.4 mg/kg min. The infusion was reduced by 25% every hour after the 3rd hour until the CRI was stopped after 6 hours. Alfaxalone group. ALF dogs received a 2-3 mg/kg IM bolus of alfaxalone, followed by IV alfaxalone CRI of 0.10 to 0.15 mg/kg min for 6 hours. Similar to the propofol group, the infusion was tapered by 25% every hour starting from the 3rd hour. All dogs were hospitalized in the intensive care unit and closely monitored. Their vital parameters, such as blood pressure, oxygen saturation, and electrocardiograms, were continuously assessed. Outcome measures, dogs were classified as responders, R+, if they experienced no further seizures during the 6-hour CRI or within 24 hours after CRI suspension, non-responders were dogs who relapsed into seizures within 24 hours after the CRI was stopped, other measures included the incidence of adverse events, e.g., apnea, hypotension, hypertension, hyperthermia, and hypothermia. Results. General population, of the 20 dogs enrolled in the study, 13 were male, 4 neutered and 7 were female, 6 spayed. The median age was 6.2 years, and the median weight was 12.7 kilogram. Most dogs were diagnosed with idiopathic epilepsy, i.e. and some were suspected of having structural epilepsy, such as neoplasia or meningoencephalitis. 11 of the dogs experienced cluster seizures before SE onset, and most were already on chronic anti-seizure medications before their inclusion in the study. Propofol group, PPF, 6 dogs, 60%, in the propofol group were classified as responders, R+, while 4 dogs, 40% experienced seizure relapse within 24 hours of CRI suspension, adverse effects were reported in 6 of the 10 dogs in this group, including hypothermia, 2 cases, hypotension, 2 cases, hypertension, 1 case, and hyperthermia, 1 case. Alfaxalone group ALF, 5 dogs, 50%, in the alfaxalone group were classified as responders, while 5 dogs relapsed into seizures during the 24-hour post-CRI observation period, 3 dogs in this group experienced adverse effects, with all 3 suffering from apnea during the IV bolus phase. 2 of these dogs required mechanical ventilation for 10 to 16 minutes, unlike the propofol group. The alfaxalone group had no cases of hypotension, hypertension, or hypothermia, but the risk of respiratory depression apnea was notably higher. Comparison between groups. No significant differences were found between the groups regarding overall success, responders versus non-responders, or adverse event rates, however, dogs in the propofol group were significantly heavier than those in the alfaxalone group, median weight, 25.3 kg versus 6 kg. Discussion. The results of the pilot study suggest that alfaxalone, administered intramuscularly followed by IV CRI, may be a viable alternative to propofol for treating canine refractory status epilepticus, RSE. Although the sample size was small and statistical significance was not achieved between the two groups, the findings indicate that both drugs are capable of stopping seizure activity in about half of the cases. The advantage of alfaxalone lies in its ability to be administered via the intramuscular IM route, making it particularly useful in situations where IV access is challenging or delayed. The rapid onset of action, within a few minutes after IM administration, could help stabilize patients for further IV catheter placement, especially in emergency settings. However, the use of alfaxalone was associated with a higher incidence of apnea, requiring mechanical ventilation in some cases. This is consistent with known side effects of alfaxalone, particularly at higher doses, which include respiratory depression. Despite this, the overall safety profile of alfaxalone was acceptable, and no serious long-term adverse events were recorded. Conversely, propofol has well-documented side effects, including cardiovascular depression, e.g., hypertension, and respiratory suppression, although it did not cause apnea in the study. It is also associated with propofol infusion syndrome in humans during long-term use, a condition that can cause metabolic acidosis, rhabdomyolysis, and cardiovascular collapse. While this syndrome is not commonly reported in veterinary medicine, its potential in prolonged CRI protocols warrants caution. Limitations of the study, the small sample size of just 20 dogs limits the statistical power of the study and prevents generalization of the findings to the broader population, the variability in treatment protocols between institutions may have introduced bias, the study also lacked long-term follow-up data to assess the recurrence of seizures or neurological deficits after the acute treatment phase. Conclusions and future directions. The findings from this study indicate that alfaxalone could be a safe and effective alternative to propofol in the treatment of RSE in dogs, especially when IV access is challenging. However, given the higher risk of respiratory depression with alfaxalone, its administration should be carefully monitored, and mechanical ventilation should be available if needed. Future studies with larger sample sizes, standardized protocols, and longer follow-up periods are needed to confirm these preliminary results. Additionally, incorporating advanced monitoring tools such as electroencephalography (EEG) could help optimize treatment protocols and better assess the efficacy of these drugs in controlling seizure activity.